Do you want to be able to better support and coach those with persistent pain who come in to see you? Do you want to be able to manage expectations and also know what to do with the psychosocial information that we receive? Well, on this episode of Clinical Communication, I'm joined by Mathilde Kehler, and we're discussing just that, how to coach and support those with persistent pain. If you find this useful, please do go and share it with others and subscribe. You can also send in questions or stories into clinicalcommunication@outlook.com, and I may well read them out. At the end of this month, I'm also doing a webinar for clinical physio with a colleague of mine and we're covering CBT and motivational interviewing. You can find the link in the description below. As always, thank you for watching or listening, and I'll speak to you next time.
And seeing how can I actually understand how are you and how are your world and how do you see it? Like, what are your glasses look like? If I put on your glasses, what does it look like? And what is standing in the way of that? Yeah.
What's their future? Yeah, not just the present, but the future as well. That's why I like that. But thank you for doing this, Matilda, as well, and giving up your time.
Yeah.
And just that's all right. And you actually, I will say, because we've spoken in the past, I don't know if it's even intentional, but just the conversation we had last year made me realize something, because people often talk about the importance of listening, right, and how we should listen to our patient and tell the story. And I realized we've been going through, when we were speaking last year, I'd asked you various questions, and then you got to 15 minutes, and I actually hadn't said a thing. Apart from the questions, and it's made me realize ever since, and reading other things, that all this communication stuff, it's definitely a two-way street. You have to obviously listen to the person, it's obviously very important, but they have to know there's a person on the other side as well that they can try and connect with. If you don't give them anything to connect with, they'll find it hard to connect back. So thank you for that, even though if you didn't do it intentionally. I just learned that off just the conversation we had, and I've been trying to do more of it since and be more, not just a good listener, but better connectors, maybe the word as well. Before we get into all the stuff about how we discuss pain with people, you, like other people I know, are more in this kind of pain coach role, as well as being a physio. Let's say someone with persistent pains turned up to see you, and you say, "Hello, I'm Mathilde, I'm a physio and I'm also a pain coach." And they say, "What's that?" What do you say?
Yeah, it's a great question. Yeah, because there's a difference about what I would try to explain to them what a pain coach is, and definitely what I would say to patients. I think if I should make it quite simple, I would say that it takes the foundation of pain science, what we know about pain today, how we understand pain today, and put you in the center of it. You as a person in the center of it. So I follow you, and what I know is that I know a lot about the pain, but it's you that is in the middle of this. So it's about you, and how can I help you? So I know something. I'm the expert in pain. Let's say that, and what we know and what we recommend. But you are the expert in your life. So can you enlighten me? Tell me how it is for you to be in your situation, and tell me how I can help. What do you need help with? What is standing in the way? What do you want? Where do you see yourself in the future? So I would definitely make it very much a collaborative conversation.
Is that a shock to people? Because just from people that in my pain world, we see some are used to having pain support info because they've had their condition for a very long time. But for others where they maybe haven't had the pain for as long, they're used to having the traditional kind of biomedical approach, having the passive, things done to them, whether it's the prescription, the being told what to do with exercises, or being given said passive injection or surgery or whatnot. And some will come in and say, "Just tell me what to do," or "I'm expecting you to solve this." And sometimes that I see the shift of where I'm going, trying to put you in the driver's seat. It's just helping you control. You're in charge. Some get a bit, I'd say, uncomfortable with that. The idea that, where they've been reliant on healthcare, They now
Hmm.
need to be reliant on themselves, almost.
Mm.
That's the best way to phrase it.
Yeah.
Uh, how have you found people react when you tell them that we're trying to put them in the driver's seat?
Hmm. Yeah. Yeah, it's a very good question. And it's also, we talk a lot about in the healthcare, if I just make this, that we talk about supportive self-management, right?
Yeah, yeah.
And the thing, I'm actually having a talk later in this spring where I'm talking about the self-management. Is it a strength or a burden? Because it can be very, very, very slap in the face for some patients
Yeah.
if or clients or whatever human beings if they come and they're really burned out, they're frustrated, they've tried all kinds of different things, and then I ask them to they really want the fix because they're tired. They're
Yeah.
really, really tired. And they really want to help me, right? So, but I think I'm not necessarily telling them what my goal is. I can say to you, I can say, well, one of my goals as a pain coach is building up your pain self-efficacy and working on your supporters, being work on self-management, and have a feeling of locus of control, and like internal locus of control, and really have a living your value-based goals. I can say all that, but they're just like. So what I say instead is actually I ask them what they want. I don't have to tell
Mm,
them what I want because that's actually not very interesting, to be
yeah.
honest. What's interesting is what they want and
Yeah.
what's standing in the way. And the thing
Mm,
about pain coaching that's a little bit different than the physio, framework is
mm,
that normally the physio framework starts in the problem. What's the problem? What's the
mm,
matter? What's the problem?
yeah.
And the pain coach mindset shifted. First of all, there's a whole very, very important step and when I talk about steps, it's not necessarily like, but the most important thing we have to do is be connected,
Yeah.
like really be connecting and really listening to the person. I really challenge my pain coach to listen for quite a long time and really taking the time, because I believe that psychologically informed practice is being present and is being there with no agenda, with about analyzing or anything, but really being there for the person and meeting them. But that's an intervention in itself. But anyway, then when we've really make this a rapport, we make this alliance, we've really make them and really showing them both in the skill set, but truly in the mindset also, and connecting as human beings, we ask, what is the goal? So we don't go in, what's the problem, and then go straight that way, because then
Mm,
the focus of it will be problem oriented. And of course that's why they're there. But in the beginning, they want to. My experience is mostly want to express how the problem is a problem. And that is what we need to meet. We need to
mm,
meet the human being. How is this a problem for you? How has it affected you? How has it affected you as a person, your family, your work life, your behavior, your mental
mm,
well-being? How
mm,
has it affected you? And that's actually the most important thing about the problem in the beginning. But after that, we really need to figure out, where do you want to go? How
mm.
can I help you? What's the end? If this is a successful uh, it's called forløb in Denmark. I'm just looking for if this is a successful help me out
Journey?
there. Yeah,
Journey?
journey. Yeah,
Yeah, yeah,
journey.
yeah,
Let's say that. Yeah. If it's or treatment, let's say that. A treatment, we see each other over time.
yeah.
And if it's successful, what do you need for it to be successful? When
Mm,
when are you done with me? When do you don't need me anymore? What should be different this time? What should be
mm,
different this time? that you would actually think this is a success. I'm done. Now I can do it on my own. What is that? What does that look like?
Mm.
Because that's where we want to go. So in the questions, it's not about now we're gonna work on pain self-efficacy. Here is 4 steps. How are we gonna do that? That's me, right? That's not
Yeah.
me being the expert. But what I really want to do is figuring out where do you want to go and how does that look? And when we
Mm.
got the goal, their goal, what is the value? Why do you want to go there? What would it give you to be there? Just really
Mm.
taking the time to figuring out the goal. Because most clients and most people with pain for a long time, they 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 have a very difficult time finding the goal. They have
Mm.
a really difficult time shifting from this, I want the pain to go away so I can live. And like they have what we call away mindset. They want, I want this to go away
Yeah.
because then I can live. But shifting the mindset, but where's the goal? Where do you want to go? Why do you want to go there? What can you do when you're there? And that is actually that shift can take a bit to figuring
Mm.
out. And also because goals can be vulnerable. They involve hope. And
Yes.
that's
Yeah.
that's not necessarily very comfortable because I've tried to set goals before. If you've been in a pain clinic, you're there's a lot of goals, and the doctor has some goals about getting you down in the medication.
Yeah.
The physio have some goals that you have to walk longer. The psychology have some goals maybe about mental health or something. So they are very much used to having goals that comes from the outside. But what do you want? If you
Mm.
really want to make a change and really want to have a goal that makes sense for you, what does that look like?
Yeah.
Because that's really person orientated. So we really follow them.
Yeah.
Does it make sense in you? How does that make
Yeah.
sense in your?
Well, it's
I think
interesting you say
you.
that
Yeah.
because my patients, before I was in a more pain-related role, you'd ask the
Mm,
classic biomedical subjective of what aggravates your pain, right? What makes
mm,
it worse? What
mm,
helps? Um, but by the time they've come to you and I, or a healthcare professional where someone's got this diagnosis, they've been through the mill of testing, we pretty much
mm,
know what's going on. I've changed that question, the AGS question specifically. So instead of asking what makes it worse, I now ask slightly differently, what do you struggle with? You know, or
mm.
how is this affecting
Yeah.
you? You know, we're looking for the impact because
Yes.
me finding out what makes it worse, well, how is that going to get me towards their goals, as you say, right?
Yes.
But asking what they struggle with, how it gives me a better idea of how it's impacting their life. Because some people will come sit down and say everything, which is fine.
Mm,
And some people say, well, just when I walk a bit, or if I work after I've worked 9 hours, but at the weekend, I'm fine. And it's just painting you a better picture, I guess, of this person and how their life is affected rather than
mm.
just the traditional biomedical solving the problem.
Yes.
It's interesting you say about the goal. Do you ask the goals early? Because I'll be honest, I ask about goals, but I often ask about goals last. Not
Mm,
for any. I haven't reasoned that. There's no.
mm,
It's just because I think one day, when I started asking about goals, it just happened to be stuck on last on my template of various
mm.
questions.
Yes.
Sometimes it naturally comes up, and I'll do
Mhm.
it then. But if it hasn't, I'll usually wait to the end. But when do you ask about the goals?
Uh, I would say early.
Early.
Quite early,
Yeah,
yeah,
yeah.
before the problem. But that it's very important for me to say um, uh, not before the first thing is listening to the problem, as you say, the impact of the problem.
Yes.
That's the
Yeah.
most important thing.
Yeah.
But going into the biomedical world before the goal can actually what we really want to achieve is putting them in the driving seat, right?
Yeah. Yeah.
So I
Yeah.
need to figure out what do you want, or else
Yeah.
it's my plan.
Yeah.
So yes, definitely. When I meet the person and learn about them and really have a feeling, do I understand you? And use all the techniques, as you know, the skill set about uh, um, summarizing, validating, active listening, making sure. So, is there anything you want to change? Have I understand you correctly if I say this and this? You know, you really have this
Mm,
feeling like, okay, we've landed the story, if you can say that. You know,
mm,
tell me your story.
yeah.
And if we gotten through that and asked all the psychologically informed question, how does it impact you? What is different? What do you struggle with? That's a beautiful question. We don't have a very good Danish word with that. I sometimes I would love to be English because you have so great words sometimes. I really do. But because struggle with is really a great word. So
Mm,
what is your challenges? What is it that,
mm.
yeah. But then I start with the goal. Because
Interesting.
if yeah, because then we help that to be the guideline of the treatment plan. That
Mm,
is the guideline. If I start in the problem, I start analyzing it over in my head. Then it's my goal. That's to fix the
yeah.
problem. So
Yeah.
if I start in their world, what is your goal? Then and it has to be like value based, right? Some are very schooled. They come in, they've been to ton of physio, ton of everything, and they go like, well, I need to walk this and this distance, and blah, blah, blah. They have very we educated them a little bit too great, right? But if we ask, what do you want as a person? Do you need to be different before
Mm,
you can say goodbye to me? What needs to be different? You've tried a ton of stuff. What needs to be different?
mm,
Because that is then we get, 5 layers down so much quicker, and we
mhm,
get to the kind of the point of, okay, it's that you want. Wow, okay. And sometimes when you go down and really take your time making the goal and really make it person orientated and make it value based,
mm,
then it's much easier to ask afterwards what is standing in the way of that goal.
barriers.
Yeah, what are the barriers for this goal? Because,
Mm.
or else, if we don't have the goal, we find a ton of barriers because we can always find, a lot of barriers, and we are schooled to figuring out the problem, right? We are
Mm,
schooled to looking for errors, to looking for the holes, to looking for where it can be problematic, but that's not necessarily relevant for the client. So
mm,
we need to figure out what's relevant for you, and how can I and what is standing in the way of that goal.
mm. So
Uh, mm,
just to be clear, you go, so ask the story, as you say,
mhm, mhm.
and then goals straight afterwards?
Yeah.
Oh, fine. Okay. I'll tell you what, I will commit to this then. Because if I'm gonna follow my own advice and tell people how to increase commitment, so I will. This is
All
going to go
right.
out shortly next week. So anyone listening to this in the week it comes out, I will change my template, and I will put goals after the story, and then I will tell you at the end of next week how it went. If that's all right.
Amazing. Oh,
Yeah.
looking forward to
Now
listening
I've
to it.
committed to you and hundreds of people, which is great. But
Which is great. Commitment is definitely something that, that we know is a good way of making changes. So that's amazing. Yeah, definitely.
well,
Yeah.
these people. So I'm thinking, as you say, it's great when they're on board with the partner, well, not even partnership, putting them in charge. Increasing our goal to increase their self-efficacy, but getting more back to their values, what's important to them. Now, I'm thinking of some people I've seen. It doesn't happen as much as it used to, but I'm sure you may still come across it. People who are coming in not wanting that. They've got their persistent pain somewhere
Mhm.
and they're wanting the fix. And they
Mhm.
may have even been told by other people there is no fix. There is no straight solution. There's no injection, no surgery, whatnot. This is a condition to manage. How do you have that conversation with them?
Hmm. Good question. Well, first of all, I'm not sure actually they land in my city. It's very rarely I have them
Fair.
because you wouldn't go to a pain coach unless you have an open mind to trying something a different way.
True.
So I don't think they land in mine. But let's just play the scenario and see if I
Mm,
can put myself in the shoes of somebody who is in a clinic
mm,
and meet this conversation in their world. I think I would go the pain communication um, if you call it an intervention, like I would understand what needs to be fixed because I need to
Mm.
understand what do they think about the pain since
Mm.
they think it can be fixed.
Yeah.
So what have you been told that should be fixed? So if I change this, if I let's say I follow them, I roll with them.
Yeah.
So if I correct your fascia, let's say that if that's what they want, they've been
Yeah.
told if I correct my fascia, this will be all better. Okay, so if I do that, how does that work? What do you imagine happens inside your body? So I again I really want to understand their perspective because if I go in I talk about often when I talk about pain communication, I talk about the bridge. Like we have the client on one side, on one island, and then we have us as a therapist or a pain coach on the other island. And then
Mm.
there's a bridge between us. And if we go in with I need a fix, and we stay on our own island and going like, I can't give you that. That's the wrong idea. That's not modern pain care. Then we stay on each island. And what
Mm.
we need to do as a clinicians or as pain coaches is to walk across the bridge and go over to them and staying there, and not
Mm.
going over there to say, okay, I go over here to meet you a little bit, but only to get you out back to my island. But actually, really, truly understanding that there's a reason why they need that fix.
Mm. Yeah.
There's a reason why they uh, they think that's the solution.
Mm.
And I before I can help them, I need to understand what it is.
Mm.
What have you been told? Why do you think that? Where do you get that from? Who has told you that? And really following them and staying it, exploring the pain, not necessarily as we talked about from amazingly Lorimer Mosley, the explaining pain, which we did in the beginning, right? But now it's really more about exploring the pain. This is not me invented. This is one of my good pain coach colleagues who says we should shift it from explaining pain to exploring pain because that's actually where the
Mm.
communication comes. So it's not necessarily me standing on my island and shouting, like pain is complex and biopsychosocial. And it's just like what is that good does that do? We need to
Yeah.
understand them.
Yeah.
So to understand them and really help them make a change, I need to know exactly why they think that, or else I will just get a general pain education, and I want to do individualized pain education,
Yeah.
which means I need to understand exactly what they think, how they think, what would make that difference. And then I can figure out, okay, so if this is happening and this is happening and this is happening, you think that will make your pain go away.
Mm.
Okay, great. And then when we really think we understand them, and they also know we have taken the time to understand that. That's very important too. You know that. I know you know that. So it's really like, really showing them and really making it very clear with all our knowledge and skill sets that we have taken the time to understand them, but also really, truly making the human conversation to accepting that not we all see things differently, and there's a reason for that.
Yeah.
So when we do that, we can then invite them. That's very important. Not tell them, but invite them. Would you be interested in another perspective? I have some other knowledge. Would you be open to? Would you be willing to, as you say, in ACT? Would you be willing to? What do you? How is that? And then we can. And they hopefully they say, yeah, sure. And then we can open the conversation.
Yeah. I think willing
So,
is a
so
very,
that's a long answer, but I
that's
but I
right.
hope it will get some ideas of how to work with it.
I think you said about willing there. I think that's a very important word that isn't maybe used enough because we talk about open questions and trying to get people to think and give their own feedback, but sometimes you have to be a bit more direct.
Mm,
Um, and would you be willing? Most people are willing to do something,
hmm
willing to consider things. It's a hard thing to say no to,
hmm
rather than could you do this or would you
mm,
do that is easier. Nah. But
mm.
willing is like, oh yeah, okay, I'll give it a go. Sure, like that, I'll be willing to try.
Yeah.
And I agree with you. You meet this person where they're at, as you rightly pointed out. What do they know? Where did that belief come from? My boss has a great phrase where sometimes were they told? So have they actually been told? Which most of the time is yes. They've been told that there is no fix, there is no cure, whatever.
Exactly. Mm.
But did they hear it? So did they choose to hear it and just take it in, or have they heard it but either not agreed with it or ignored it? You know, where is this? Is that if they've been told there's no fix, but have they read about it online or seen someone else or something that's made them go, well, no, this consultant's wrong or this doctor's wrong. I can get this fixed, and it's okay if it's not the right time. I think, you know, if they're still looking for said fix, we can drip feed them stuff and find out, you know, what they've been told and try and, as you say, not just bring, you're not just going to go meet them where they're at and then bring them straight over. It's a small process and there may be bumps in the road, excuse me, and they may go backwards at times and up and down. And that's okay because sometimes people need months, years to accept that there isn't the fix and or at least needs a different approach. Perhaps is a better way to phrase it. There's no surgery or injection or thing that will just suddenly change it for them. They need to, need isn't the word, but consider things from a different perspective, and that takes time. But I agree with you entirely. It's meeting them where they're at, not just saying, no, you're not got a fix, you need to accept and manage instead.
Hmm. Yeah, yeah, and it's again, it's very interesting for me when people say that. I want to know what is the goal. Again, back to the goal. That is
Yeah.
like we say in the coaching world, we say if you don't have a goal, you don't have a coaching session. Because
Mm,
that's like the line of it. So when they say I needed a fix,
yeah.
and we go over to their islands, if you take the bridge metaphor again,
Yeah.
and we have this, I want to know. I want to stay on that island, not necessarily to pull them back to me, because then I
Mm.
actually have a mindset that I'm still the expert. Does it make sense? So,
Yeah.
so
Yeah.
we
Yeah.
have to, we actually have, if we go over to them, it's
Mm.
literally with the mindset and the human understanding of truly understand their world, not necessarily to manipulate them over to us again, because then there will be this resistance about me being right and you being wrong. And I don't
Yeah.
believe that. I actually believe that every person really wants to feel good and they are
Mm.
really the expert of figuring out what that is, but
Yeah.
maybe they don't know what this fix look like. So what
Mm.
can you do when you're fixed? I don't
Mm.
mind rolling with their words
Yeah.
and just like what does it look like? What can you do then? What is this pain preventing you from that you want to do? What do you want to feel
Mm.
that you can't right now? So again, when we stay in the goal asking, um, and they said, I just want to go it to go away. You're
Mm.
kind of like, okay, I can understand that. It must if I had pain all the time, I would be so frustrated. I really understand why you want this to go away. But that,
Mm.
and then let's play with it. What would it look like if this was gone? And then they can get this. And again, then the goal is the guideline and not the what's right and what's wrong and come over to my island, but really truly staying with them. And
Yeah.
they got it from somewhere, you know. I really I'm I truly believe, and I'm so sorry about all the people that I've done this, you know. I've said biomechanical reasons for their pain. I did it. That is how I was teach. So they got it from somewhere, right? And
Mm.
if we want to look for a fix, well, that's easy. You can just go online. There's a lot of people who want to fix you. So they don't get it from somewhere that's really bad or I don't know, stupid or something. There's a really good reason they have these mindset. They have this um, understanding of the world because that's
Mm.
what we taught them.
Yeah.
I think we have a very big responsibility of cleaning up our mess as physios and as doctors, and I
Yeah.
think really we need to make it very clear about I truly understand. Yes, and a good way also can do, and if they have a very biomechanical way, is saying that, yeah, you know what, I understand. I had the same understanding of pain not
Mm.
5 years ago actually, but something has changed in the pain world. There's a new
Mm.
way of understanding. Would be interested in listening to more of that.
Yeah.
So really understanding that this it's okay. They have this belief because it's understandable. It really is.
Yeah.
It is a primarily understanding of pain. It's a medical one, right? So
Yeah.
it makes sense. It makes
Yeah.
sense.
Yeah.
Yeah.
I like that, actually, admitting that in the past we were wrong as well. You know, when
Mhm.
we talk to patients now about, actually being active helps good joint health, if we say that as an example. In the past, we used to think that running would wear out our knees, or
Mhm.
doing lots of bending would damage things, etc. And we know that's now not true. But I
Mhm.
found that actually, when we talk about certain things, we've changed our positions on over recent years, things like manual handling and posture and just
Mhm.
exercise and the effect it affects the body. Sometimes admitting to people, yeah, we used to think this way, like you do,
Yes.
admits that almost I guess you're meeting them where they're at, but you were in the past, obviously,
Mhm.
um, shows a bit more uh, humanity, if that's will, more that you're not just the expert, you were wrong. And
Mhm.
sometimes when you admit kind of errors or faults, they're more likely to accept you as more of an expert at times, actually, as well.
Yeah.
And
Yeah,
you,
and you can say all the clinicians that listen to this podcast, I would believe that if you had a shift of mindset, it's so uncomfortable.
mm,
It's so uncomfortable to acknowledge that, wow, this is not how the world maybe it could look different. Wow. Oh, that's very painful for us, actually. It's very uncomfortable. And that is actually what we're asking our patients to do. And we ask them to do it on a whim. Like, can you do this? No, this is a new way. And it's just like, we're like pulling the what's it called, blanket, is it called the blanket, we're
yeah, yeah,
pulling the
you pull a
blanket
blanket, yeah, yeah,
under them. It's just like we need them, we need another thing and another narrative, you can say,
mm,
and we need to give them something new and really give them the understanding of it's difficult to change your mind about pain. Trust me, I've taken ton of courses. When I heard about it the first time, I was amazed and thought about giving up my totally career as a physiotherapist because I didn't understand. This is what I've been teaching. So I understand it's really, really difficult for you to wrap your head around. It makes sense. It's okay. Hey,
yeah,
let's figure it out how I can help you. Let me be here as a guide on your side. You can ask me all the questions you want. I have a ton of research. I've done a podcast I can refer you to. So whenever you're ready to learn some more, uh, don't hesitate to reach
mm,
out or contact me. And if there's a good place, and also help them a little bit on their journey, and maybe say, if there's one place you should start, it maybe start listening to this podcast or whatever, something
mm,
quite easy, right? So it's not necessarily, but most of the time, I don't necessarily need them to come over to my island, if we say in that way, because if the goal their goal is the goal of the treatment.
yeah,
That was a
yeah,
lot of goals.
yeah,
But if their goal is the goal of the treatment, then we just follow that.
yeah.
And when something stands in the way, that's when we pick up perhaps pain signs, perhaps not.
I really
Maybe
like
we
that.
don't need pain
Yeah, yeah.
communication necessarily.
No, the narrative doesn't have to change for them potentially. Yeah, yeah, yeah. Because
Maybe it's a
they're,
behavior thing. Yeah,
yeah.
yeah.
I agree with you entirely. I'm sure there's tons of people who we've suggested some the whatever routine we've suggested, whether it's the lifestyle changes, the exercise, whatever, they've got better with it, but their perception of what's wrong may still be very biomedical. But
Hmm.
does it matter ultimately if they've got better or they're managing? Um, there are we have some patients who we see in our service long after they've gone, and they come back occasionally, and they're most of them managing pretty well, and they will still occasionally talk about their discs that have popped out,
Mm,
or their worn out joints and certain things, which isn't true. There's but we don't need to correct them. Like, they're
mm,
managing, it's fine, and I think you're spot on. Like, you meet them where they're at, but you don't have to bring them back to where you are. The way that they manage this condition, or the goals, maybe not what you envisioned,
Mm.
but you'll get there.
Yeah, exactly.
It might take a lot of time. It might not
Mm.
be with you who they end up managing with. It may need someone else. You just may plant the seed where they then later on
Mm.
come. You may have experienced it. I'm sure I have, where I've said the same thing to someone, and maybe it's because it's the second or third time they've heard it. They've then gone, "Oh, okay, all right,
Mm.
well, I'll give that a go." Um, and sometimes people just need to hear it from multiple sources.
Mm.
We both want to talk about, because you said about psychological informed practice, and we said
Mhm.
biopsychosocial area, very big buzzwords,
Yeah,
obviously. Um,
yeah.
when we have students in the past that kind of come around our service, they often comment that especially in the pain world, we are almost like the true epitome of biopsychosocial. Um,
True what?
uh,
Say that word
uh,
again.
um, how biopsychosocial assessments and management it truly should be.
Mm.
Other services may claim to be considering biopsychosocial, but it's almost like a bit of a blanket statement that, to tick a box. And we were discussing earlier, and you want to talk about this. Someone may come in with psychosocial factors that are affecting their pain, whether it's stuff
Mhm.
at home, past experiences, mental health things, social things with their social life, perhaps family, etc. And I think most clinicians now will ask, "Who's at home? What do you do for a job? What do you do in your social life?" More, not all, are asking, "How's your mental health?" The question then we often get is, "Okay, I'll ask, but what do I do with that?"
Mhm.
So what should we do with that?
Hmm. Ah, it's a great question. Really is. Yeah. That was actually kind of what I my way into the what do you call the mental world or psychologically informed or all these practices. That was me being very sharp at asking psychosocial questions and then opening people up. And then I had no clue what to do after that. I was just like, okay, I know how to ask these questions, but then what? Then
Mm.
what? What should I do now? Okay, how is this relevant? How can I make it relevant for them? Why I ask, you know?
Yeah,
And it's just
yeah,
like, okay, is it just for me to check out a box, or is it something that's relevant for them? And that's also questions I think we need to ask ourselves as clinicians, right? When we follow protocols and all the recommendations, they say you need to screen for psychosocial factors.
yeah.
And then what? What should we do about it, right? So
Mm.
we learned all the screening tools. We learned all. Let's do a start back, right?
Yep.
Okay, now we got the numbers. Then what?
Yeah.
And that's actually, is it just for our knowledge to know that they have a perception of pain, or is it something that we can bring out and talk about and make relevant for them? So yeah, it's a very, very good question, how to do it. The more I used to say, the more I learned about pain, the more I understand I need to learn about people. And
Mm.
that's because we need to, again, not necessarily to repeat myself too much, but it really is about the human, right?
Yeah, yeah.
So it's
Mm.
is it but it's when you say biopsychosocial, it's also a big word to understanding. How do we understand as clinicians the biopsychosocial model?
Mm.
Do we understand it as a cause, like this is the cause of it? We're finding out, do we see the biopsychosocial model through a biomedical lens? Like
Mm.
we try to tick off, okay, they have prior history of depression, for instance. Just a tick off, okay, that's a reason, that's a cause. That is still one to one in the understanding of pain. Or do we see the biopsychosocial model more as a like George Engel would say, like the humanizing way, the holistic way of it? Is it just meeting? We need to meet the humans and the persons. Is that's the way? So
Mm.
why do we ask the questions? Do I ask them because I have an understanding that I need to fix then the depression because the depression is the reason for the pain? Does it make
Mm.
sense? Do you
Yeah,
follow
yeah,
me? I don't
yeah,
know if
yeah,
I explain
yeah,
it
yeah.
quite early, but it's the thing about, are we looking for causes to pain that needs to be fixed? Because that's
Mm.
one way to ask psychosocial questions. The other way to ask psychosocial questions is to figuring out how has this impacted you, right?
Yeah.
Which is another mindset.
Mm.
And I don't necessarily, and this is very important for me to say that I don't necessarily think it's an either or. I don't necessarily think one is wrong and the other one is right. I think we need to embrace both because if there's one thing we can say about pain, there's a then it's that it's complex. And if there's one thing we say about humans is that oh my God, we're complex. So we need to figure out how to navigate confident in this very complex thing about a conversation with a human being in pain. And then we need to both have the mindset and our skill set and our knowledge about the psychosocial questions being, is there any kind of course here? Is there something I need to take into my treatment plan as
Yeah.
well?
Yeah.
Because that could be a contributor to the pain. Or am I asking because I want to meet you as a person? And that's two very different kinds. But to your questions, what do we do with it? Then that's hopefully also what I've answered. So if we ask about what is the cause of it, like do I need to have referral to somebody else? Do I need to have somebody else in over this treatment because I can see this is beyond my professional skills,
Yeah.
what I can do? Do I
Mm.
need somebody else to go over? Or when I ask the questions and we start to, do we ask them to make them reflect? Then we are asking in a more psychologically informed way. So we ask to make them reflect on
Mm.
if there is something else, if the pain maybe is more biopsychosocial, then we are asking the questions as a step also in the education, you could say, or the pain communication.
Yeah.
Does it answer your questions? I
I
don't know.
think so. And I agree with you
Yeah,
because I think we
yeah,
can ask about these things, but as you
yeah,
say, it's what effect is it having on them?
yeah.
Like, someone could have had abuse earlier in their life or real difficulties,
Mm,
but have they had support for that? Have
yeah.
they, been able to access help, been able to get all the resources? Great. And actually, I'll be honest with you, we find that people that, if they've had difficulties in the past, if they've been able to get the help for that, whatever talking therapy it is, they are then, when they come on our, especially group programs, they're much more engaged, I think. And they actually make it easier for those that haven't had much psychological support to understand the need for it, or not always need, but why it's important, let's say at times.
Mm,
Someone could be barely leave the house, but do they mind? They might be very introverted. They may not want to leave the house at all. That may be their
mm,
comfort blanket, if you will. We can identify these things that can all have an effect, could have an effect, but actually, what is the effect? Because what we consider potentially a negative, maybe they're
mm,
positive, for example. And as you say, if someone needs help, you're not, I think the phrase is going away now. People often worry that they have to, if we ask these things, then we have to be psychologists. No, you don't have to be a
mhm.
psychologist,
No.
but it's important to ask. So then if they do need help, you can direct to whoever said help is. And if you don't know where the help is, and you find out, like you would if they'd come in with a sudden new, I don't know, if they come in with a prospective new ankle injury they've just done on the way here, and you think they may have broken ankle, you'll send them to A&E, right? If they're coming in with lots of mental health difficulties and you think they need help, well, you refer them to the psychological support, wherever it is, okay, wherever they need to go.
Mm,
No, so no one's asking anyone to play psychologist, but
no.
if we are to be truly biopsychosocial, then that we should be able to at least ask and direct.
Yeah, definitely. And also I think some of the psychologically, let me say it right, this psychosocial questions,
Mm.
uh, they're quite normal. So now when we talk about it, we talk about very, let's say, very heavy stuff like abuse or things like this. It's very
Mm.
heavy. And of course, there's a referral there. But some of the psychosocial questions is, are you worried? And most people in pain are worried. And that's actually normal. So we also need to figure out what kind of degree is this, because of course you're worried. If I have pain, I get worried.
Yeah.
That's normal. So we don't need to um, pathologize. Is that the word? I
Yeah,
don't
yeah,
know if
yeah,
it
yeah,
is.
yeah,
Yeah,
yeah, yeah.
things that is quite normal when you experience pain.
Mm,
So it's also taking into consideration. Okay, are you worried? What are you worried about? Okay, is this
mm,
something I can ask? Is it something that I can help you um, uh, uh, clean up? I have in my I have this tool I use that is called, I don't know if it sounds that great in English, but it sounds great in Danish, let me say that. But it's called, I think it's called a worry cleanup, like a
okay.
cleanup of worries.
Yeah, yeah,
It's just
yeah.
like, okay, you know what? Let's take them all, right? Let's take them all. Okay, bring it on. Let's take them all of everything. Is there one more? What else? What else? Really empty the worrying. Okay, that's a difficult word. Sorry. Really emptying it out, so we really get that cleaned up, because that can
Mm,
cloud for the process further. And then we really understand. Oh, you're worried about that. Ah, okay, I can understand that because you have been told XYZ or something like that. So it's also to figuring out some of this, or if you're afraid to move, well, that's also normal if you have an understanding that your disc is going to pop out because you've been told that. So it's also we ask also these questions to understand them again, to figuring out,
mm,
okay, what is it that I can help you with? And how is this standing in the way of what you want to do with your life?
mm.
Yeah.
I realize I'm looking at the time here. So instead of asking what I was going to ask and all that I'd planned, I've got one question that I was going to ask left, which
Yeah.
was different to what we've been planning.
Okay.
And that is,
Great.
what's the future of pain coaching, do you think?
Oof. Oh, and you think that's an end question? That's a good one. Okay. Well, I hope, and I also believe that the pain coach title will be more normal. And I
Mm,
hope it really will. I actually really hope I've made this pain coach education in Denmark, both to lift the standard for what a pain coach is, because it's not a protected title, and I really think it's not something that you should take easily.
mm,
So it's a half a year where you really learn this, and you
mm,
really it's quite ambitious clinicians who've chosen to dedicate in a half a year to understanding pain, to really connect and really to learn the coaching communication, and help people with primarily persistent pain. But I also think that I hope that pain coaching will be as normal as stress coaching, for instance. Like it's
yeah.
like when I have pain, it's also normal for me to go to a pain coach, because for hopefully the paradigm shift in I don't know, what do you say, 50 years? I
Maybe.
don't know, 20, I hope.
Yeah.
But still we need to acknowledge that the paradigm shift about understanding that pain is more complex than we thought. Um, uh, I think there's still a couple of years of that. But anyway, I hope it will be more normal to also taking in, oh, of course, I also need to manage my pain. I
Mm,
hope that if you get on back, if you hurt your back on your work, then you have a pain coach in your company that you're assigned to straight away. So you
mm,
get actually early care. So you really get, how can I manage this myself? So I'm just not out on a sick leave for 6 weeks. But as soon as I get this, for instance, if you got a sick leave with stress, you would be addressed to a stretch coach, right?
yeah.
So is there any way where we can get like early on self-management skills to figuring out what is the best thing I can do? Or if you're out with any kind of, I hope also that in the future, hopefully, as you say, some clinicians would love to dive into this.
Yeah.
Probably a lot of your listeners, I would guess so.
Yeah.
But there's definitely also somebody who's not at all interested in the psychosocial world, and they are not. They don't maybe they maybe can see that the evidence is pointing in the direction that we need to take it into considerations, but they don't find it interesting. And that's okay. I don't think everybody should be pain coaches. I
Mm.
think hopefully that you will get somebody who's specialized. So when a client come in and with the back pain, and we did the screening with, for instance, the start back, and we can see, okay, they have a high score of this. Then we say, you know what? To give you the best treatment, I would recommend that you stay with me. We start on this back training rehabilitation program, and you get 3 hours with our pain coach.
Mm.
Because then that let's say exercise physio is very exercise orientated and is very good at exposure, for instance, and he's very good at strengthening, conditioning, and all that kind of stuff, which is amazing and is also really have a place. And then there is somebody who loves having the conversation, who is really good at it and who has the understanding of it and have the interest in it, right? And then they have a different setting, perhaps taking in contextual factors, for instance, right? So there's not there's not anatomy posters on the wall. Here we sit on two chairs, for instance, and we talk about your pain and how it's impacted you. And we still have the pain science with us. But we still also work on how is your perception of this? What are your goals? What do you want to do? How can we collaborate with the physio at the same clinic to do this? So we have these pain coaches who love to talk about this and want to help in that way in collaboration with the more maybe exercise orientated or exposure orientated physios. So it's not either or, but it's just really developing what are your interests, right? Yeah, and
And
what are you good at? Yeah. Does it make sense?
yes, and it's starting to
Mm.
go this way here, slowly,
Yeah,
very slowly,
yeah.
because we're having more, the government would say, community pain
Mhm.
support, where the people are being supported by not healthcare professionals per se, not like a qualified physio, psychologist, OT, whatever, but someone with a bit of experience, often coaches, health and wellbeing coaches or something like that, who are acting in this kind of pain coach role. And then,
Mhm.
as you say, the physio, OT, psychology is there if they need it, but they've got that person who has that specific coaching role who can help. And I think that's where we're going to be going.
Yeah. And also different settings, most of all, because one of the big barriers, if we take about how to work more biopsychosocial, a lot of us physios, we want to work biopsychosocial, but there's a lot of environmental barriers for that,
Yeah,
most of all time.
yeah,
That is like the biggest barrier of all, right? It's the time.
yeah.
And if there is a different setting about, well, now you're going to see a pain coach, then maybe that could be an hour and that could be something different. That could hopefully, I don't know, I'm just dreaming, and that's a good thing, I hope. And we'll see how it goes. Let's check in about 5 to 10 years. Let's do that.
Awesome.
Yeah.
Um, Mathilde, people can find you on LinkedIn and
Yeah.
on Instagram.
Yep.
Uh, Anywhere else?
Yep. My website.
Your
Then what
website.
to contact me, of course. Yeah. So
And
it's
if
the yeah.
there are some Danish listeners to this, because I know from the demographics, if our
Yeah.
Danish listeners want to do your pain coaching course, where should they go?
That's also my website.
On the website.
It's linked everywhere, so it's not difficult to find it all. It's the pain coach education, so it's quite simple. And I really hope that can help those who are interested in this way of,
Yes.
of, of working with it to navigate more confident and more, yeah, navigating more confident in the complex pain world and the complex human world. Yeah,
Yeah.
definitely.
Excellent.
So thank you for having me.
Well, thank you for doing this. And I
Mm.
will repeat my commitment to earlier that I will, by the end of next week, was that mid-February, state how it went with my asking the goals after the story. And I'll
Oh.
tell you and everyone else how it went.
I'm looking forward to it.
Thank
Yeah.
you.
Thank you for having me, Ben.